All right, the survivors, those of you that are still hanging in here late in the afternoon. In the interest of time, we'll just get moving forward. We have 3 case presentations, and first up is Jerry Matteo, who joins us from Jacksonville, Florida, an interventional radiologist that was formerly here with us at MUSC as a fellow. And Jerry's going to present management of escape veins and non-maturing fistulas.
Thanks for having me. I don't have any disclosures. So the title of my talk is Endovascular Ligation of Venous Side Branches, otherwise known as escape veins, in non-maturing fistulas. Everybody remembers this big escape, 1995, this guy. If you look in the Stedman's Medical Dictionary, you will not find the definition of escape veins. If you looked in a regular dictionary, you'd see lots of different definitions of it, but we're going to be using side branches and collaterals for escape veins. So escape vein collaterals are common after the creation of native AV fistulas or PTF graft placement, and many times it's unavoidable by the surgeons because the surgeon devotes most of their time to the anastomosis. Often the surgeon doesn't have the opportunity to ligate these collaterals along the venous outflow. Escape veins impede laminar flow and preclude equal pressurization within the venous outflow, and equal pressure is vital and essential to the maturation and arterialization process of the vein. So escape veins are often inadvertently punctured during hemodialysis. We've all seen these types of pictures before. Anytime an unrecognized through-and-through puncture happens, it can cause excessive post-hemodialysis treatment bleeding and swelling of the extremity. Venous outflows can be improved in fistulas that are not maturing secondary to escape veins using endovascular techniques for exclusion or ligation, and recognition and early exclusion of these escape veins is essential to salvage young non-maturing fistulas and maintain function. So we're pretty busy as far as dialysis. In our practice, we do about 10 a week, which turns out to about 500 to 600 a year. And the original treatment plan, of course, was you would see a fistula, and there's the corresponding schematic below it. And the patient comes and has an issue, and you would basically, if there was no stenosis and there was nothing else to treat, you'd probably look at these escape veins and say, well, probably this is the problem. And here they're labeled B and D, and you'd end up getting in these with a catheter. You exclude them with coils. You do a follow-up fistulogram. The escape veins are excluded. The patient usually does better. So how do you choose who gets this and who doesn't? Do you just eyeball it? Do you estimate it? Is there ever really a criteria for exclusion of escape veins? Anybody know that movie? Alcatraz. And then the question is, is this even worth it? There's an expense to this. So we put together a research project, and the hypothesis is that excluding these escape veins with collaterals with gradients of greater than 5 will improve hemodialysis blood flow rates and function of the fistula. And the way we did this was we took intravascular pressure gradients proximal and distal to the venous outflow escape veins, and then this is prior to and following either coil embolization vascular plugs or stent grafts across the offending collaterals. So here's a typical fistulogram. You can see there's escape veins here on the proximal venous outflow. The remainder of it is widely patent, centrally widely patent. So what we did was, the schematic is the A, B, C, D, E, B and D being these escape veins. We use a NAMIC preceptor manifold device, which is connected to an end hole, set it to 0 to atmospheric pressure, and then open it to the intravascular pressure, and you get these pressures. So in this particular case, A, proximal was 54. We actually got into some of these escape veins, 44, 33, 32, and then distal to the escape veins along the venous outflow is 31. So the gradient is really A minus E, which is 54 minus 31, which is 23, which is greater than 5. So we treated this particular one with a stent graft. As you can see, the escape veins are excluded. And we took a measurement of proximal, distal, 32 minus 32 is 0. So another case, exclusion of plugs, same idea. This happened to have all Jacksonville patients have 2 escape veins close to each other. And here, B and D, 41 proximal, 33 and a 33. There's your gradient, A minus E is 41 minus 33, gives you an 8. So we plug this one, and as you can see, we took pressures all the way across, and then in this particular case, that little escape vein wasn't important. There was no gradient, so we didn't do anything to it. So A minus E, once again, we brought our gradient down to 0. Here's another guy, two escape veins. Proximal and distal, this time distally is 40, 46, minus 40 is 6. We put 2 Amplatzer plugs in here, and you guessed it, got a gradient down to 0 again. Now, if you look at this case, you'd say, well, wow, there's a large one. You know, do you even need to do a pressure across one? Look at how prominent that is. And we did. And we have a pressure of mean 35 and 34, no gradient, no intervention. Now here's a huge one up in the cephalic arch here, prominent escape vein. You'd say that's got to be stealing something away here. Took some pressures proximal and distal to this, 20 and 20, no gradient, no intervention. So you might say to yourself, well, why? Why would that happen? Well, here's an exit here in China, and you can see the exit ramp is just loaded up with cars, and you see the main outflow here is widely patent. So basically, we're dealing with competitive flow. Here's another way to look at it. Here's the top and the bottom. If you look at the top, there's a little narrow escape vein, but that's wide open, and maybe there's a car fire or something like that going on. There's a problem with the main outflow. Meanwhile, on the bottom one, you see a large escape vein, and the cars are flying through the venous outflow because you might be dealing with a competitive flow. Now here's sort of what we call the flagship case. It looks like a spider web. I mean, look at all those escape veins. They're everywhere. As we look closer, just like this warden did in Shawshank, you can see that there was a stenosis for sure up in the cephalic arch, and we took care of that with an angioplasty. And then we took some gradients. We did our A, B, C, D, E again, and we've got 51 and a 28, what gave us a gradient of 23. Put a covered stent across it. As you can see, the escape veins are excluded, and you guessed it, 32 minus 32 is 0. We pulled the catheter back, 2 more escape veins, because they always come in pairs. Distal, proximal, 31, 38, it's a 7. This time we chose to use some coils, same patient, same procedure, coiled them up, and we did a post-procedure, and got a gradient of 0. This one here, squiggly wiggly, venous proximal, venous outflow for sure. You're going to have a problem here. Proximal and distal, you can see the mean of 21 and the mean of 24. So no gradient, no intervention. So this last one here narrowly escaped an intervention, just like this seal narrowly escaped the jaws of this great white. So what we did was we took these 10 patients that we've been using, and we measured blood flow rates prior to and following embolization. You can see the middle column is the devices we used in a variety of different stents, coils, and plugs. And here's all the next column is what the gradients were before the intervention. And the interesting column of this whole chart is that all of the gradients went to 0 after they were intervened. And we took the same 10 patients, plotted them on a graph. And this is 1 month, blood flow rates 1 month prior to intervention and 1 month following intervention. As you can see, the vast majorities have improved dramatically. So, how does this happen? Why does it happen? I'm going to explain it with a little physics 101, a little touch of electrical engineering. So, VIR, what is that? Everybody knows, vascular interventional radios. But what about this? How about V equals IR? That's voltage, current, and resistance, which could also be the same as, voltage can be the same as pressure, current could be the same as flow, and resistance could be the same as stenosis. It's a simple circuit. Heart, artery, goes to the capillaries, you get some resistance, and it goes to a vein. When you put a graph in, you basically get rid of the resistance. So when you look at this slide here, this is a simplified circuit model of a hemodialysis graph with escape veins. Now if you look at the electrical current, you have your V1s, V2s, your V is your voltage and your I is your current, and we're using IE as the escape veins. And on the other side we're using P for pressure, and we're using flow and IE for the escape veins. So when we look at it like this, we're going to be using Kirchhoff's current law, Ohm's law, and Kirchhoff's current law. So Kirchhoff's law is pretty easy. What it says is IE2 equals IE1 minus IE minus IE1. And now IE1 and IE2 are the escape veins. So what it's really saying is if you put a buck in on I1 and the escape vein steals away 50 cents, what's left? 50 cents. Same thing. If you If it was taken away 25% or quarter, you'd have I2 would equal 75. Ohm's law basically says that V1 minus V2 equals I1 times the resistance, which we said is really negligible. And then you plug and chug and you get Kirchhoff's law. When you put those two together, you get Kirchhoff's voltage law, which is V1 minus V4 equals V1 minus V2 plus V2 minus V3 plus V3 minus V4 as you go across here. I know it's a little bit tricky to see with the red on the black. Or plug and chug, and you kind of get this, which is V1 equals V4 by way of V4 minus V1 minus, and don't worry about the resistance, minus the escape vane minus the escape vane. So if we assume that V1, which is the corresponding to the systemic venous pressure, which is constant throughout the graph, we can conclude that V2, V3, and V4, which corresponds to the graph pressure, will increase if we render the escape vanes to zero by the placement of some type of embolization technique, such as a stent, plug, or coil. So here's the easiest way to look at this. You hook up a light bulb to a battery, shines bright. You hook up two more light bulbs, and you would think that intuitively that they would all shine bright, but actually they'd all look like this. You'd have to cut off those two to get the first one to be bright again. And anastomosis is similar to a faucet. You turn it on, it flies through centrally. It's all the same pressure all the way through. Now you have an escape vane, which is like a hole in the hose. And what's going to happen? This? No, this. Thank you.